Des Des is a 12-year-old boy who was diagnosed with pervasive developmental disorder and ADHD at the age of 4. His previous school requested that he be reevaluated by a psychologist, and the reevaluation deemed him to meet criteria for an autism spectrum diagnosis. Because of his interfering behaviors, he was referred from a public school to a private education school where he's currently enrolled. His classroom has no more than 7 students and is staffed at a 2-to-1 ratio plus the teacher. Des lives at home with his mother and father and his typically developing 7-year-old sister. It's important to note that Des also has documented symptoms of anxiety and OCD, but does not have a formal diagnosis for either of these. The target behavior I chose was to reduce perseverations. When Des was first enrolled in the private special education school, he engaged in a high rate of aggressions. He had significant language delays and rarely engaged in spontaneous speech and engaged in a high rate of perseverations. Since being enrolled in school, his aggressions have decreased and his language skills have greatly developed. However, he still engages in an extremely high rate of perseverations, which have kept him from engaging with his classmates, interacting with peers, and making friends, along with they oftentimes keep him from attending to instruction. And for this reason, this behavior was the focus for reduction. For the purpose of this project, a perseveration is defined as Des repeating the same question or phrase more than once in a 30-minute interval. If Des changes the format of his question or phrase, but is still talking about the same subject, it should be counted as a perseveration. For example, if Des says, I want to glue, and then says, I can glue when mommy comes, these are all perseverations and should be counted as such. A functional analysis was done, and perseverations have an attention component, as he directs most of his perseverations to a preferred staff, and he often asks questions he already knows the answers to. However, it's important to note that there is also an anxiety component, as Des is very sensitive to his environment changing and if students are absent. So those are often topics of his perseverations. He also perseverates on his compulsions and being denied access to his compulsions. So if he can't close the door, turn off the lights, or touch an electronic device, these are topics he'll often engage in perseverative speech about. I chose to use frequency as my measurement because the behaviors have a clear beginning and end, and data is taken at my school in a 30-minute time block. So I thought this would be the best way to show if there were any significant changes based on the treatment in the behavior. I chose an A-B design, and I felt this design would best show the function, if there was a functional relationship between the treatment and the behavior. And because perseverations aren't dangerous, there was no ethical concern with stopping treatment and returning to baseline phases. The baseline phase was staff were instructed to respond to all of Des's perseverations with either a comment or request to stop or to provide it some sort of verbal attention. Baseline data was taken in 5 observation sessions, and each observation session lasted 30 minutes. The treatment was first that Des was to be read a social story called Saying Things Once. The story explained that what a stuck thought was, which is a perseveration, and explained that staff would answer his question one time. And after that, he was shown a red card that had the hand signs finished and said, we've already talked about that. Unlike in baseline, staff were to respond one time to Des's perseverations, and all subsequent perseverations were put on strict extinction and no verbal attention was provided for it. He was also shown a video of him engaging in appropriate conversation, along with having his class rules that included saying things once gone over every 30 minutes. When he didn't engage in a perseveration for a 30-minute time block, he was given a preferred edible with a behavior specific praise. IOA data was taken in 60% of the baseline phases. The first treatment phase had IOA data at 37%, and the second treatment phase had IOA data at 44%. The results indicated that the treatment worked. As you can see, there was an extinction burst at the beginning of each treatment phase where the frequency was higher than the baseline, but after the extinction burst, the behaviors steadily decreased so that they are lower than the previous baseline stages. DES did not meet criteria for generalization to be done during the project, as he did not reduce his behaviors by 50%. However, generalization was for the family to implement the same treatment procedures as was being implemented in school. I believe that my intervention worked because behaviors during treatment phases after the initial extinction burst significantly decreased, and during the second treatment phase, there was a shorter extinction burst. Plans for the future are to fade out the red card to just a finish sign, and then eventually to fade out the finish sign to staff just holding up 1 for DES, signifying that they are only responding to his question 1 time.